Yes.
What's a normal caseload?
For
I don't know, behavioral health, addictions, how many clients does someone normally see?
if you work at our facility, because facilities vary a bit too, at Recovery Plus, we have gender-specific groups. So in that all-day programming that I was talking about that we offer, we run 4 women's groups, 4 men's groups, and we have 2 older adult groups. And each group has a cap at 10. We have, in our primary, we have what we call a pod system. So we have a pool of 20 clients, 2 LADCs, and 1 mental health person that works together to manage those 20 patients. And so we have the mental health person can be independently licensed, does not have to be independently licensed because it's not a separate billing where you need an independent license. And so we, again, try to treat the whole person. And so those 3 people are responsible for those, but independent, you'd be responsible for a group of 10. You'd be doing the charting, you'd be doing the management, you'd be helping them with whatever their crisis of the moment is. We have 2 older adult groups. And I actually thought that was a great name till I got old enough to be in the older adult group. Now I'm not so sure, but anyway. And we did it for a number of reasons. In our older adult group, we have 55 to whatever. The oldest patient that we've had in addictions treatment that I can remember was 90. But your life issues, when you're at that point in your life, are very different. You don't have, you're not worried about getting your kids to school. You don't have those kinds of stressors, but a lot of times you may be very unhappy because of the loss of having your children at home, widower, being alone, lots of aches and pains and those kinds of things. We also have found that depending on hereditary and drugs that you've used and alcohol, that there are sometimes some dementia issues. So our older adult area is more confined. We have a very large building, and so you can spend a lot of time getting lost in it, and so we've tried to do it that way. When we first initiated our older adult group, our older adults came in with alcohol use issues. Now they come in with alcohol use issues, but we're also seeing a lot of opiate addiction, methamphetamine addiction. We're seeing marijuana addiction. Some things that we didn't see before. We are seeing a switch in the aging of the population as the baby boomer generation, where there was a lot of drug and alcohol experimentation. As that group has moved now into that part of our program, or in that age group, we have seen that shift. In St. Cloud right now, as in the rest of the country, opiates are very prevalent. There is a large amount of heroin in St. Cloud right now. We're finding it in our high schools, in our, in some of our middle schools. Meth is still fairly prevalent, but heroin has overtaken meth. And a lot of times the heroin gets started because somebody had an injury, went to their doctor, got prescribed an opiate, painkiller. Your you're done with your painkiller, your doctor says, no, we can't keep refilling that, you should be okay by now. You've unfortunately become addicted, and now you have to find some way to feed that addiction. Heroin is much more readily available on the streets than opiates are.
And cheaper.
And it's cheaper. Yep, it's cheaper. So we see those swings. And right now, that's what we're seeing. A lot of, in all of central Minnesota, in all of our, in all of our bigger cities, large cities, but, we're talking Long Prairie, Melrose, Albany. It isn't confined to some big city anymore, as sort of heroin is thought of to be. The other thing that I want to mention is addiction is a disease. It is not a life choice. Nobody in their right mind ever said, you know what, I think I'm going to start drinking alcohol. I'm going to drink it to excess. I'm going to black out. I'm going to act stupid. My family is going to leave me, and I'm going to end up homeless on the street. That's my life plan, and I'm going to do that. Nobody does that. You don't know that you're going to have an addiction issue till you have an addiction issue. There's chemical imbalances, there's differences in brain, and you don't find out until you start drinking. I have a son who's been in long-term recovery from both drugs and alcohol. And one of the discussions he and I have had since he's been in recovery was, if you're a social drinker, and I drink socially, I always eat before I'm going out, and if I start, if I have my second glass of wine, because that's about as far as I can get, and I begin to feel that little bit of buzz that most of us have felt at one time or another, I stop. And he clearly says, I do not understand. That's what I live for. That's my whole point in using. There is a difference in how his brain is wired from what mine is. And he didn't know that until he started drinking, and he was an alcoholic at 14. But he didn't know until he started and really liked how that felt. So that's probably one of the takeaways. It is a disease, and it's a chronic disease. We've always treated it episodically. It's a chronic disease. Just like diabetes. You get diabetes, you don't get to go to the hospital once. They tell you how to do things. You take, you use your insulin, you watch your diet, and boom, for the rest of your life, you never have a problem again, because most people don't so consistently watch their diet or whatever it is. So addiction is starting to be treated as that chronic disease, and there's going to be different kinds of cares into the future for rehab folks and long-term case management, and some things that we haven't had up till now, because you can't treat it like, average length of stay in treatment is 30 days. So you come in, we treat you for 30 days. Now you're in a confined setting, so for 30 days, for the most part, you do okay. And then you go back out, and life hits you right back in the face, just like it did before, and you have a relapse, and then you've got to pick yourself up, and you've got to do it again and again and again and again. And we would never tell someone with a heart condition or somebody who was diabetic that they can't have any more care because they just can't figure it out. And we can't treat addiction like that either. It isn't about figuring it out. Believe me, addicts haven't figured out, they just can't stop. Not won't, can't. And it makes it easier if you remember that every single day, that nobody is there because they want to be, truly. My life was going so good, I thought I'd take a break and show up at your clinic and stay with you for 30 days. No, nobody wants to stay with us unless they don't have, you know, if you're homeless, it's not as bad, because honestly, in the wintertime, you know, we give you a bed and we feed you and you know, but nobody does that. So it's an important thing to remember. People don't do bad things to themselves any more than they have depression on purpose or, you know, schizophrenia on purpose. You just don't do those things to yourself. So if you all can remember that as you go forward in your work, that'll be helpful too. As you can tell, this is a field I'm passionate about, and I think it's very important. The other thing, anybody who's looking to get into the field, please, we have such a shortage of people coming into the field for LADCs, you know, any part of the medical field, rehab, you know, counseling, everything. There is a huge shortage, and so your timing is good. You're going to be in demand. And I don't see that changing. Frankly, in the addictions field, 100 years from now, we're going to have an addictions field because it's not something you do to yourself. So, you know, but when you're done, you're going to be able to find jobs. You should be able to find internships without any problems. Those of us who work in the field are so thrilled that all of you are coming into the field. So, you know, take that away and know that, because you're very valuable. And like I said, there's such a shortage. I was at a conference, a statewide conference a couple of weeks ago, and as directors do, we try to pick each other's brains and figure out what everybody else is doing and what we can do and all of those things. And the main topic was our workforce and what do we do and how do we find the people we need and encourage people to keep coming into these fields that are challenging. So as I said, I don't think any of you will have problems finding jobs, and that demand will continue. I don't see that going away anytime soon. So, questions? Things I didn't cover.
What would you like to see LADC interns know that they currently don't know when they show up to start with you?
Definitely an understanding of the documentation piece, an understanding that you will need to do some lectures, some teaching. You know, I think if there's one thing, if you come in and you have empathy and caring and understanding for any patient you're going to serve, the rest of those skills we can teach you. Never been able to teach somebody empathy. You know, if you don't really like the clients or patients you're working with, we can't fix that for you. So I think the other prevalent is the co-occurring. To be very aware of the co-occurring. So you get dependence and you get depression. You get dependence and you get schizophrenia. We are, as I said, co-occurring, and there's some natural depression that comes with ending up in treatment, because, as I was saying, nobody decides to go there, so, you know, you've lost everything. It would be natural not to feel so great. But to really have an understanding, and it doesn't make any difference which came first. They need to be treated together. And so if you can be aware of that, particularly, there are some treatment centers that are smaller, and there's some here in the area that are outpatient, and so they do like 3 hours of group and not every day. And they don't do as much with the co-occurring. They will outsource that. But to be aware of that you're going to find both, no matter where in the field you work. You can't have addiction, rehab, those needs, and not have it be difficult. And then to come in knowing that it's okay that you don't know. We don't expect anybody to come in and know. You're gonna learn, but I don't think I've ever had an intern that hasn't said, you know, I learned a lot of good stuff in school. I just didn't know it was gonna quite be like this, or that this would happen, or that would happen. And so we can help you through all those things, but to learn all that you can when you're here. I don't know all the courses you're taking. I'm gonna find that out a little later today, but I don't know all the courses you're taking. And I'm very glad that they have had this program started. It's very needed, and that you're all involved in it. So those, I think, would be the things. I tried to talk about the documentation piece and the reasons why, because students often come in and don't realize that part. And then it's like, why didn't anybody tell me? The other piece that sometimes happens, and it just happens from all the schools, if you are coming into this because you are in recovery, or because you have some reason on your own, and while you were using, you made some poor choices, and you have some legal issues, please take a look at those. Work with your counselors here about what they are. There are some times when it makes it tough to get licensed. Not impossible, usually, but tougher. And I think you just need to be aware of that and work with that from the beginning. And I don't know that people hear that in school. And
It's a long process, and you should start right away.
yes, it is. So if you think you've got something, talk to somebody. They'll let you know how the Department of Human Services, which is the licensing body, will take a look at that and what you might need to do. There are hoops you have to jump through. It just can take a while, and I don't think that everyone knows that. And if you get to licensing day and you don't know that, you can be pretty disappointed when you find out that you got to jump through the hoops on the back side instead of the front side. So if that's something that you wonder about, ask. People make all kinds of mistakes. It's not anything that hasn't happened to lots of other folks, but be proactive. And I don't know that people coming from school always are aware of that. And I don't know that, everybody knows that it can be a problem. I'm not sure that schools don't tell you about it because they don't want you to know. I think they don't tell you about it because they're not always aware of which things become problematic and which don't. So.
I was thinking along the lines, Carol, of the 6 dimensions, basic treatment planning.
ASAP
1225.
criteria, yeah. And, at this level, do you do things with treatment planning? I'm showing my ignorance of your program, and I apologize for that.
Okay, we integrate it within the course, but we don't have all the different courses, but we don't have one specific course that focuses on treatment plans. But it's, again, integrated throughout all the especially second year. And then in regards to providing information about if you have a criminal background or addiction issues, of course you do not have to have, for the RCE, because we have 2 different programs.
Yeah.
The RCE and then the RAC. So for the addiction program, you do have to be qualified not have any sort of substance use. For the RCE, they're not required. We don't do any screening for that.
No.
So
no, and you wouldn't need to do screening for that, although, if you got something going on, check yourself and be aware. For the addiction program, you have to be 2 years free of chemical use problems. not from using alcohol. Don't use illegal drugs, you know, but if you have